This video will highlight some facts about non-steroidal anti-inflammatory drugs. Hi, Dr. D here. The access to non-steroidal anti-inflammatory drugs vary among countries. In some countries, it's available on prescription or over the counter, while in other countries, it's available in the front shop. This class of drugs is used to treat osteoarthritis or gout or rheumatoid arthritis or some common conditions requiring pain relief like headaches or dysmenorrhea, and it's also used to treat fever. NSAIDs differ in their antipyretic, analgesic, and anti-inflammatory activities. The resources used can be found in the description below. Arachidonic acid is the primary precursor of prostaglandins. Thromboxanes and leukotrienes are related compounds, also synthesized from the same precursors. These compounds are also referred to as eicosanoids and are released in allergic and inflammatory processes. Prostaglandins control many physiological functions and have a major role in modulating pain, inflammation, and fever. Let's have a closer look. Prostaglandins sensitize sensory nerve endings to nociceptive stimuli, leading to the generation of pain impulses. It resets the thermoregulatory mechanisms in the hypothalamus, which is the body's thermostat, to above the normal 37 degrees Celsius. It increases the temperature set point, and therefore prostaglandins play a role in fever. It causes vasodilation and increased capillary permeability with resulting edema, which are typical signs and symptoms of inflammation. Inflammation is a biological response of the immune system and can be triggered by pathogens, which refers to bacteria or viruses or any other microorganisms. It can also be triggered by damaged cells or toxic compounds. The signs and symptoms of inflammation can be remembered with the acronym SHARP, where S stands for swelling, which is brought about by the edema due to the increased capillary permeability. H for heat. Vasodilation generates heat, but it also refers to the increase in the temperature set point. A for altered mobility due to the pain, but that is also a way of your body protecting that area. R for redness. Vasodilation leads to redness, and P for pain. NSAIDs act through the inhibition of the synthesis of prostaglandins and are indicated for low to moderate pain, but it can be used as an opioid-sparing agent in more severe pain. Let us look closer to the actual mechanism of action of NSAIDs. Arachidonic acid is an essential fatty acid and a component of cell membranes. When cells are damaged by, for instance, trauma, the enzyme phospholipase A2 becomes activated, which then releases arachidonic acid from its attachment to the membrane phospholipids. Cyclooxygenase catalyzes the formation of prostaglandin, and 5-lipoxygenase catalyzes the formation of leukotrienes. These are the two main groups of eicosanoids. The eicosanoids released from a tissue or cell will depend on the particular set of enzymes contained within the cell. For completeness' sake, the letter refers to the specific ring structure of prostaglandin, and the subscript refers to the number of double bonds in the fatty acid chains. Prostaglandin G2 and H2 are unstable intermediates and lead to the formation of prostanoids, which is a collective term for prostaglandins and thromboxanes. Prostaglandins activate specific prostanoid receptors in target tissues and exert their effect on smooth muscle, platelet aggregation, neurotransmission, and other biologic activities. Thromboxanes act on smooth muscle and platelet aggregation. The leukotrienes are produced primarily in inflammatory cells, including mast cells, basophils, eosinophils, and macrophages. Leukotrienes C4 and G4 are secreted in the presence of asthma and anaphylaxis and play a major role in bronchospasms. For this video, however, I will focus on prostaglandins and non-steroidal anti-inflammatory drugs. The main mechanisms of action of NSAIDs is the inhibition of the enzyme cyclooxygenase. It decreases the cyclooxygenase enzymes, and the net effect is a decrease in the production of prostaglandins. Cyclooxygenase enzymes come in two major isoforms in the arachidonic acid pathway, COX-1 and COX-2. COX-1 is a constitutive enzyme necessary to keep the house in order. It has a cytoprotective effect on the GI tract and catalyzes the formation of thromboxane A2 required for platelet aggregation and homeostasis. COX-1 enzymes are present in relative constant levels in various tissues. On the other hand, COX-2 is an inducible enzyme and is rapidly upregulated during the inflammatory process. It is present at low levels in normal circumstances in most tissues. Different types of thromboxanes and prostaglandins have different pharmacologic effects and often are opposing effects. Prostaglandin I2 inhibits platelets to adhere to each other, while thromboxane A2 stimulates platelet aggregation. Prostaglandin I2 and E2 cause vasodilation. These prostaglandins play a role in maintaining pulmonary blood flow and maintains the patency of the ductus arteriosus in a fetus until time for its closure. So this has got to do with the fetal circulatory system. Prostaglandin E2 and I2 have an important role in modulating renal flow and glomerular filtration. Prostaglandins produce a cytoprotective effect on the GI mucosa. Prostaglandin I2 inhibits gastric acid secretion, while prostaglandin E2 and F2 alpha stimulate the synthesis of protective mucus in both the stomach and small intestine. Prostaglandin E2 and F2 alpha furthermore stimulate uterine contractions and increase gastrointestinal motility. Because non-steroidal anti-inflammatory drugs inhibit prostaglandin synthesis, their use can cause or exacerbate renal disorders and may counteract the antihypertensive effect of antihypertensive medications when taken concurrently. Prostaglandin increases water and sodium excretion and therefore exerts an antihypertensive effect. Both COX-1 and COX-2 participate in renal homeostasis. I will come back to this in a little while, but let us first look at the different NSAIDs available. NSAIDs are divided into two groups based on their COX selectivity. Non-selective NSAIDs inhibit both COX-1 and COX-2 enzymes. Aspirin is the only NSAID that irreversibly acetylates and inactivates COX enzymes. Suppression of platelet thromboxane A2 formation underlies the cardioprotective effect of aspirin. The effect of aspirin lasts for the duration of the platelet's lifespan, which is approximately 10 days. Low-dose aspirin inhibits platelets in the portal circulation before it is metabolized to salicylate on first pass through the liver. Low-dose aspirin exerts its effects only on platelets and has no systemic effect. The other commonly known non-selective NSAIDs include diclofenac, ibuprofen, indomethacin, etc. Inhibition of COX-1 is responsible for the prevention of cardiovascular events, but unfortunately also for most adverse events. Celecoxib reversibly inhibits COX-2 enzymes. Inhibition of COX-2 is thought to lead to the anti-inflammatory and analgesic actions of NSAIDs. But where does paracetamol fit in? Paracetamol is a potent inhibitor of COX-3, which is a splice variant of COX-1. It has analgesic and antipyretic properties, but exerts no anti-inflammatory action. It is therefore not classified as an anti-inflammatory agent. It is, however, effective when used concurrently with other NSAIDs for supplemental pain relief. Whenever supplying medicines, you have to confirm whether it is appropriate for the particular patient. Click on this link to watch the video on the 3 phases of dispensing. Always check for therapeutic duplication, because more than one NSAID should not be used concurrently. Doing so can result in an increased risk of gastrointestinal or other side effects, for instance, impaired blood clotting. Or it can lead to an increased potential for adverse interactions. For instance, aspirin displaces some NSAIDs from plasma proteins, increasing their serum levels, which can lead to toxicities. This, however, refers to the anti-inflammatory doses of aspirin and not the low dose. Remember, low-dose aspirin exerts no systemic effect. Ask your patient whether he or she is taking any other medicines. Because, for instance, NSAIDs inhibit the renal excretion of lithium. And should the patient be on lithium, the NSAIDs can lead to an increased level of lithium serum levels. NSAIDs reduces the clearance of both methotrexate and aminoglycosides, which can then lead to toxicities. Potassium-sparing diuretics, for instance spironolactone, together with NSAIDs can lead to hyperkalemia because NSAIDs causes a retention of potassium. NSAIDs furthermore prolong bleeding time, and should the patient be on warfarin, which is an anticoagulant, it may augment the risk of bleeding. Ask your patient about any other conditions or comorbidities, for instance hypertension. Prostaglandin increases water and sodium excretion and exerts an antihypertensive effect. NSAIDs inhibit prostaglandins and may counteract the effects of antihypertensive medications. Resulting edema due to prostaglandin inhibition may worsen heart failure. NSAID can cause or exacerbate renal disorders. And remember the elderly, they might already have impaired kidney function. Inhibition of the vasodilatory effect of prostaglandin E2 and I2 in the kidney will reduce renal perfusion. Ask your patient if he or she is suffering from peptic ulcers. It is always good to advise patients to take NSAIDs with food to reduce the local effect on the GI mucosa, but the GI adverse effects are mainly due to a systemic effect. Remember, COX-1 enzymes are constitutive, and prostaglandins exert an cytoprotective effect. Non-selective NSAIDs inhibit both COX-1 and COX-2 and have more adverse effects when compared to COX-2 selective inhibitors. NSAIDs should be avoided during the second half of pregnancy due to the risk of premature closure of the ductus arteriosus and impair fetal circulation in utero. When used late in pregnancy, it may increase the risk of postpartum bleeding or hemorrhage. The effect on the uterus can furthermore prolong gestation or inhibit labor. Ask your patient whether he or she might be suffering from asthma, because NSAIDs have the potential to cause bronchospasm and worsen the condition. It should be used with caution in these patients, as prostaglandin inhibition can cause a shift towards leukotriene production and cause an exacerbation. COX-2 inhibition has been associated with an increased risk of cardiovascular events. And this is due to it depressing the formation of prostaglandin I2, therefore its vasodilatory effect. Mature platelets do not express COX-2, and COX-2 selective NSAIDs are therefore devoid of antiplatelet activity. All NSAIDs, except now for the low-dose aspirin, carry an increased risk of cardiovascular events and is discouraged in patients with established cardiovascular disease. Salicylates are excreted into the urine and can affect uric acid excretion. For this reason, aspirin at anti-inflammatory doses should be avoided in gout or in patients taking probenecid for the management of gout. Remember to ask your patient about any known allergies. Hypersensitivity to aspirin and NSAIDs may present with vasomotor rhinitis, urticaria or hives, bronchoconstriction, asthma, hypertension or shock. NSAIDs are contraindicated in patients with aspirin intolerance due to a possible cross-sensitivity. Remember the 5 R's when recommending or supplying NSAIDs. The properties of different NSAIDs are very similar, but treatment must always be individualized due to the variation in patient response as well as the incidence and types of adverse effects. The general public widely uses NSAIDs. The many contraindications, cautionary use, and adverse effects make it crucial to ask the necessary questions and to educate the patient accordingly. Remember to always work within your scope of practice and according to your country's rules and regulations. If this video was meaningful to you, please give me a thumbs up and subscribe to my channel to see many more interesting videos to follow. Thank you and bye-bye.